Hello and welcome to Necrosis. This talk is presented to you by Romana, Miha, Joanna, Travell, Sally and Darnat. Necrosis is cell death due to disease, infection, ischemia or cell injury. It can be reversible or irreversible. Both may be activated by the same damaging agent leading to cell death.
Reversible cell injury. Functional and morphological changes are reversible if the damaging stimulus is removed. Damage to the membrane and the nuclear dissolution is limited. Cell death. This is irreversible and occurs from persistent noxious stimuli. This is seen by blebbing and ionic swelling of the mitochondrial membrane. There are two types, necrosis and apoptosis.
This picture shows apoptosis and necrosis.
Severe damage to the membrane causes lysosomal enzyme leakage, leading to cell digestion and a preventative inflammatory response production. Apoptosis is programmed cell death and part of homeostasis. It occurs when the cell is deprived of growth factors or when the cell's DNA or proteins are damaged, resulting in cell suicide.
There is nuclear dissolution without loss of membrane integrity. Morphologically, there is no cell-to-cell adhesion, with cells becoming smaller, rounder, and often lobular, with the organelles remaining intact. The final stage is phagocytosis, without cellular leakage, subject to metabolic pathways and extracellular substances like inhibitors or inducers.
Morphologically, necrosis is a result of intracellular protein denaturation and enzymatic digestion of injured cells. There are three changes occur: the accumulation of calcium salts, formation of myelin figures, and the separation and crystallization of membrane cholesterol. Cellular content digests and a host response takes several hours to develop, resulting in no detection changes.
An example is myocardial infarction. Myocardial necrosis does not become apparent until 4 to 12 hours later. Early detection within 2 hours is possible by analysis of the blood. Intracellular changes include plasma membrane alterations, mitochondrial changes, endoplasmic reticulum dilation, and nuclear alterations and cytoplasmic changes, which will be mentioned in more detail later on. Cellular swelling can be seen in Picture B. It is a reversible alteration which is noticeable during macroscopic examination of the organ. Affected cells also cause pallor, increased turgor and mass. Microscopic examination may display small clear vacuoles within the cytoplasm. This process is known as hydrophobic change or vascular degeneration.
Another mechanism has been suggested to lead to cell death, autophagy. This is an active signaling process triggered when a stressful environment arises and there is a need to auto-digest a cell's portion of macromolecular constituents. This is distinguished by the swelling of the intracellular organelles and the non-lysosomal cell death similar to that of necrosis.
There are two types of causes, congenital and acquired. Congenital causes include genetic defects, which can result in pathological changes and can cause cell injury due to deficiencies of functional proteins, such as in enzymes and in inborn errors of metabolism. When these are beyond repair, cell death is triggered. Variations in the genetic makeup can also influence the susceptibility of cells to injury by chemicals and other environmental insults. Acquired. This is due to alteration in the chemical environment of the cells by injury. Examples include hypoxia, which is oxygen deprivation, with ischemia being the most common cause of necrosis. Other examples include physical agents, aging, nutritional imbalances, and chemical agents. Cytoplasmic changes also occur when necrotic cells show increased eosinophilia. The cells may have a more glassy, homogeneous appearance than viable cells. Enzymes with digestive cytoplasmic organelles cause the cytoplasm to become vacuolated and display a moth-eaten appearance. Nuclear changes assume one of three patterns due to chromatin breakdown. Karyolysis is the basophilia of the chromatin which may fade. Apiconesis, characterized by nuclear shrinkage and increased basophilia. Karyohexis, the pycnotic nucleus undergoes fragmentation.
Dead cells can be substituted by myelin figures. They can also be further degraded into fatty acids or phagocytized by both other cells.
These fatty acids bind to calcium salts, resulting in the calcification of dead cells. Necrosis is further differentiated into various types, in accordance with their appearance macroscopically. The most common type of necrosis is coagulative necrosis, usually occurring due to acute infarction. We are now going to talk about patterns of necrosis.
Coagulative necrosis. This occurs primarily within the kidneys and heart by ischemia. It macroscopically appears anemic, firm and opaque. The firm texture can be due to the injury denaturing not only the structural protein, but also enzymes resulting in a blocking of proteolysis of the dead cells.
The tissue has decreased staining with hemotoxin and eosin and contains no nuclei. There is little structural damage, so the cell outlines are preserved, giving an appearance of ghostly cells. The pictures seen show normal and coagulative necrotic tissue of the heart, both macroscopically and microscopically.
Liquefactive necrosis is caused by bacterial and fungal infections, e.g. in part of the brain due to the lack of any substantial supporting stroma. The acute inflammatory reaction releases potent hydrolytic enzymes which produce a proteinaceous soup. The gross appearance is liquidy and has a feeling yellow appearance due to pus. Cystic cavities produce, which can cause the formation of an abscess. These are pictures macroscopically and microscopically of liquefactive necrotic tissue in lung.
Caseous necrosis macroscopically has a cheese-like consistency. Histological appearance includes few nuclei but no ghost-like appearance, structure not preserved, and has a pink granular appearance. It has similar features to coagulative and liquefactive necrosis and is mainly seen in tuberculosis infection. The lesions are identified as tubercles. It occurs as part of a granulomatous inflammation, harmful and toxic outcomes of the microbacterial cellular wall. Here is a normal and caseous necrotic tissue of the lung and also a microscopic image of
Fat necrosis occurs in tissues with high lipid content by traumatic injury or enzymatic injury. Inflammation of the pancreas is an example of enzymatic injury. Acute pancreatitis is caused by leakage-stimulated digestive lipase. The gross appearance shows irregular yellow-white focal points of fat. Microscopically, it presents inflammatory cells such as neutrophils and lymphocytes. Here's an example of fat necrosis in the pancreas.
Fibrinoid necrosis is prominent in atheroglomerular arterioles, and any deposition of fibrin within small blood vessels can be associated with thrombocytopenia and red cell fragmentation. An example is malignant hypertension, causing fibrin and protein leakage through necrotic heart muscle, thus resulting in the area becoming deeply eosinophilic, containing fine granules. Fibrinoid necrosis is identified only by histological examination. Fibrinoid and fibrin have similar staining patterns with H&E staining. MSB is a modified Mason's trichrome staining technique which highlights fibrin deposition. An alternative stain is Mallory's PTH, which involves a combination of hematins allowed to mature over many months with oxidized potassium permanganate. This results in clearly defined dark blue fibrin structures. The pictures to the side demonstrate normal and fibrinoid necrotic tissue, micro and macroscopically.
Gangrene is not a distinctive type of necrosis, but is a term commonly used within clinical practice referring to black, dead tissue. It is commonly seen in the lower limbs and extremities. Dry gangrene has a similar pattern of necrosis to coagulative, whilst wet gangrene occurs in the presence of gram-negative bacteria. Gas gangrene also occurs by deep tissue infection with a Clostridium species. This leads to a buildup of gases within the tissue and can be fatal if hemolysis occurs. Treatment includes urgent surgical removal of the affected tissue. The images above show various types of gangrene which have affected the body.
Treatment is based on the etiology and therefore treated accordingly. Treatment examples include treatment with antioxidants to remove reactive oxygen species from hypoxia, antibiotics, anti-inflammatory drugs for wounds.
Chemical agents react with skin, eventually leading to different patterns of necrosis. Acid burns lead to coagulative necrosis, while liquefactive necrosis arises from alkaline burns. Washing with water immediately can limit the burning process. Surgery is the most common and final treatment option.
To summarize, necrosis is the premature cell death by external factors. Injury causes lysosomal leakage leading to inflammatory responses. Clinically, necrotic tissue is classified as gangrene and later differentiated macroscopically into various patterns as seen in the table. Currently, treatment procedures are dependent on the etiology of necrosis, but usually results in surgical intervention. Thank you very much for listening, and please refer to the wiki for references.